This is me. I'm Angela Hunt. Good morning. And that is my colleague, Caroline Inch.
Good morning.
Good morning, everyone, and welcome to B&M Care's Dementia Awareness webinar. My name is Angela Hunt, and I'm the Sales and Marketing Director for B&M Care Homes. And with me today to present this webinar for you is our Director of Dementia Care, Caroline Inch. A warm welcome to our existing families joining the webinar today. And also welcome to those of you out there who have been struggling with a recent diagnosis of dementia for a loved one and trying to navigate your way through accessing further information and support. B&M Care have been operating care homes for 51 years now, and we have 28 care homes in our portfolio with a new site under development in Milton Keynes. We have a lot of knowledge and experience of caring for older people and especially supporting people who live with dementia. We take the view that providers like us have a real responsibility to share our knowledge with our families as well as the wider community. So today's webinar is part of a series of discovery events that we deliver, which includes the Funding Long-Term Care webinar, the Virtual Dementia Tour, and our new Level 1 Dementia Awareness Accredited Training Programme. You can pop back to our website, bmcare.co.uk/events to sign up for any of those upcoming dates. So let's move on to today's event. You will see that we've got your cameras turned off and your audio muted. If you do have a question as we go along, you are welcome to add it to the chat and we will do our best to cover these off as we go. If we don't reach your question, then we will be happy to respond to you on an email after the webinar. We are recording, so a copy will get sent to you within the next couple of days. So moving on to our host for today. Caroline Inch has worked in the care sector for 28 years, starting her career in care homes, progressing to care home management, and then into senior operational and dementia-related leadership roles. Caroline has a first-class honours degree in Dementia Studies from the renowned Bradford University and now steers B&M Care's vision and innovation around the delivery of person-centred dementia care. As you will soon see, Caroline is very passionate about research, evidence-based dementia care, and ensuring that all of our residents experience the very best well-being whilst in our care homes. Okay, so I'm going to hand you over now to Caroline, who is going
Thank
to take you
you.
through today's seminar. Over to you, Caroline.
Oh, lovely. Thank you, Angela. So thank you for joining us this morning. We want you to go away having learnt or been helped in some way. So we have pulled together a number of objectives. The webinar is accredited. I can't remember if you did say that, Angela. Sorry. So it's CPD accredited. So if you are a professional and you want this towards your CPD, you can pop us an email and we can get a certificate emailed out to you. So the aim of the webinar is for you to learn a little bit about dementia and how it can affect your loved ones. Also, we use the term around behaviours of distress, which is something that we may see in later stages in dementia. So we do explore that and how to interpret that. And also, we feel it's important to learn a little bit about person-centred care and how you can apply this at home if you're looking after your loved one. And also how care homes in your community can help and support you on your journey. So to begin, we always think it's very useful to give a bit of an overview of the most up-to-date dementia data. So currently in the United Kingdom, we have 950,000 people living with dementia. 1 in 11 people are over the age of 65, and we have just under 20,000 people living with young onset dementia, and that means that they're under the age of 65. You may have heard of a term, it's not used very often these days, called early onset. Now that doesn't refer to the stage of dementia, it's to do with the age of dementia. 1 in 3 babies today that are born today will go on to develop dementia. And we found that to be a very, very powerful piece of data because it is a ticking time bomb and it is our duty as providers in health and social care to be able to educate and inform and support people in our community that are experiencing dementia. So there is a lot of research out there and a lot of people champion dementia now, which is amazing. And, you know, this is something that we really do have to get behind. Now, we don't have, or we haven't had a national dementia strategy since 2009, some 15 years ago. So there is work at the minute, I believe, in government that's, pulling something together because we are at the stage where we do really need to look at, as a nation, how we tackle dementia. So it is important. It's part of what we do. It's our passion. We have an aging population, so it's something we need to be mindful of, and we need to be mindful of the journeys that, the people experiencing dementia go on, but also families and loved ones as well. So, dementia is a condition that affects the brain, and dementia is an umbrella term to describe a number of symptoms to include issues of memory, communication, and language. There are over 100 different types of dementia, but we have four common forms of dementia, and they are Alzheimer's, vascular dementia, Lewy body, and frontal lobe dementia. Getting older and having memory relapses is very, very different to dementia. So losing the keys or your door keys or your car keys is very, very normal. But holding your car keys in your hand and wondering what to do with them is not normal. We also find with old age that the language and finding the right words is modestly affected by the aging process. And also the speed of processing information does gradually slow down. But this is normal aging, and this can start in our mid-40s. And I experience that now myself. So forgetting words and having them on the tip of your tongue or walking into a room and thinking, what am I doing in here, is totally normal. And there are lots of things that impact our memory, such as, having a lot of stress and problems, poor diet, lack of exercise, deficiencies such as vitamin D, vitamin B, and iron, and also a lot of research and a lot of things on social media these days around menopause as well. So all of these little things can impact a person's memory. What we also use in dementia care is the term executive functioning, and this is the process of information in order to plan, make decisions, and problem solve. And what we find with dementia is that people may have difficulty with their executive functioning. And we often observe this when we have a resident in a bedroom, perhaps getting stuck on a job such as washing or dressing or putting their trousers on wrong or or two shirts on. Another example of impaired executive functioning dementia is around the poor judgment, disorganisation, disinhibition, and inappropriate behaviours as well. And we often hear from stories of families or other professionals about people living with dementia found wandering the streets in bedclothes or not wearing suitable clothing in bad weather, for example. So dementia does impact in many different ways, and it's not just with memory loss. So as we spoke about in the last slide, there are different, risk factors for developing dementia. The biggest risk factor is age. So the prevalence of developing dementia increases with our age. Also, we have our lifestyle and we also have genetics. They all play a part. There are lots of things that we can do to prevent dementia. Simple things such as keeping a good weight, eating a very healthy diet, reducing our stress, which is, hard to do in today's world, and also keep an eye on blood pressure and our cholesterol, and also taking regular exercise. There was a 2022 study carried out in America that also found that low blood levels of vitamin D were linked to a higher risk of dementia. Now, we live in a country where we don't get, much, well, we do get sun, but, it's hit and miss, really. As Angela said, it's sun shining in Hemel Hempstead today. But you can boost your vitamin D levels from diet and supplements, and when you can, get out in the sun. There are also certain conditions that may present like dementia, but with treatment, they can be reversed. So that is, your low iron, urine infections, feeling poorly, chest infections, and also, as I said, the B vitamins as well. So these can all impact cognitive functioning and present like dementia. So if you are feeling a little bit, under the weather and you're worried about your memory, the first stage would be to have a blood test to rule out any other conditions that could be happening. So in this section, I like this slide because it kind of gives you a bit of insight into how dementia can affect the brain. And we use this a little bit quite often in our training because it's very important to have an understanding of how the condition does impact people. In person-centered care, which is a theory developed by Tom Kitwood, we often focus a lot on the psychosocial element of dementia care. So we don't place a lot of emphasis on the clinical element. But it's important for us to understand how dementia does impact the brain, because then that supports how we care for people. So the brain has four lobes of the cortex, and they all do things very, very differently, and dementia affects them differently. So behind the eyes, for example, is your frontal lobe, and this controls your emotions, what we say, what we do, our planning, our executive functioning, which we spoke about earlier. The temporal lobes, which is at the side of the ears, is the part of the brain that's all about knowledge, understanding, memory, communication. It also controls inhibition and mood. So we often wonder if this part of the brain is affected by dementia. Is that why we see an increase in perhaps sexualized behaviors, inhibition, and also people's moods fluctuate? So they become low, tearful, or maybe slightly challenging in their dementia. And then we also have the parietal lobe. If that's damaged, it affects the process of planning. It increases poor spatial awareness and bodily awareness and dexterity and motor skills. Now, that can affect a resident or someone living with dementia in very many different ways. So the mobility issues will also increase the risk of falls. It can impact diet because they're not able to grip a knife and fork appropriately. And they may also bump into objects, which then increases their risk of injury. So it's very interesting and important to know what part of the brain is affected. And then at the back of the head, we have the occipital lobe, which is all about visual perceptions. Now, the occipital lobe helps us make sense of what is coming through our eyes. And if there is damage to this part of the brain, that will impact the way in which a person with dementia sees the world around them. And that could also impact the way in which they interpret colours, lines, shapes, and patterns, which is why it's very, very important to consider your dementia environment. Now, we do pay a lot of attention to this at B&M Care, and we have our own wellbeing by design, which has been pulled together based on a lot of research and best practice. So we try to incorporate colour coordination, reduce geometric shapes and patterns, have wayfinding, correct signage, colour contrast. And again, all these little things, can be replicated in your home as well. So dementia does impact in many, many different ways. So in this slide, we look at notable behaviours and how they may present in dementia. And this is now thinking about sort of the psychosocial element of the person-centred care. A loved one with dementia may exhibit a behaviour that challenges. There's lots of different terms that we use in the sector, but for now it'll be behaviours of distress or behaviours that challenge. And we always will look at these types of behaviours as a form of communication or an unmet need. People living with dementia may exhibit these behaviours because they're trying to tell you something and they're trying to communicate, or they're trying to express how they feel. And most behaviours of distress may appear to be challenging, and this happens when there is this unmet need. So when a person with dementia feels disempowered or losing control, they will try and take back control. And we often see this presented in many different ways when we have residents come in and stay with us. And they may show behaviours such as hoarding, refusing to bath or to wash, refusing to, to eat or drink. And this is around having that sense of control and that autonomy over their lives, feeling in control of their lives, holding on to something, holding on to that dignity and self-worth, telling you no. So we have to work around that and support people. We also see a lack of focus. That's when you cannot sit still, walking with purpose, maybe pacing or wandering. And, these are all behaviours of distress, but we need to really look at the reason why people present like that. How do you identify pain and discomfort? What are they trying to tell you? And then we spoke about earlier on the loss of peripheral vision. If we don't communicate face on, we end up with quite a high startled response, which could lead to a person hitting out, aggressive or angry. And we have to then recognise that we have brought about that behaviour through our own approach and our own actions. Difficulty recognising people. This is called facial agnosia, and this is often reported in Alzheimer's and attributed to the memory impairment. Now, that must provoke so many different worries and concerns for the person living with dementia to look at a loved one or a family member and not recognise them. We have and often see an increased risk of shadowing. This is where somebody with dementia will be by your side, following you around. And it's largely to do with your loved one or a resident feeling scared or vulnerable. And so we have to often, give them a lot of support and make sure people feel supported in these situations. We also look at alternative reasons for these behaviours on our next slide. So there are other reasons why we see behaviours of distress. Pain and discomfort is a big, big issue. It's a big challenge, and we're fortunate enough to be rolling out a piece of tech at B&M Care called Pain Check. When pain and discomfort is undetected, it can cause a lot of changes in behaviour. Pain is one of the most common symptoms that people with dementia experience. However, it's often poorly recognised and undertreated in dementia. And the main reason for this is as dementia progresses, your loved one's ability to communicate pain becomes more difficult, which is why we do need to treat pain appropriately and recognise the signs of pain. And it's always in our protocols, the first port of call. If somebody is experiencing a behaviour of distress, we will look at, are they in pain? So we always rule in and rule out pain. Then we have general poor health, and this can contribute to behaviours in dementia. It could be, as we said earlier on, infection, a UTI, a chest infection. It could be anything, sore gums, sore feet, a painful, finger that you don't know about. So poor health can also contribute to changes in a resident's presentation. Low mood and depression are another reason, as well as having negative feelings. If a person with dementia has depression, it can make their problems with their thinking and memory so much worse. Depression may also make changes in their behaviour worse as well. And we may see people present in a way that's more agitated or short or aggressive. A person with depression due to their diagnosis, again, is having all these feelings around loss of control, changes in their life, potential move to, a care home. Maybe they're not able to do what they have always done, their little jobs around the home, the roles that they used to undertake. If they're a younger person living with dementia, what was their job, their career. So depression and dementia can almost go hand in hand. We have to look at the real reason why people are depressed, and it shouldn't just be a label that's applied. Then we have side effects of medication, and they could also increase the risk of behaviours of distress. And we see this a lot with medications such as antipsychotic drugs. Now, we do sometimes, have residents that are on them, and we have protocols for that, but they can cause serious side effects to include daytime sleeping, drowsiness, confusion, shaky, unsteady, and reduced mobility. We always work within the NICE guidelines and a framework that promotes person-centered care, and we will always work with our GPs and clinicians. One of the most powerful elements of dementia is understanding where people came from, their life history. If your loved one is going into care, I would always say, give the homes or the carers, the home carers, as much information as you can on that person. Our lives shape who we are, and it can really help people with dementia share their stories and enhance their identity. And it's really useful when they're having difficulty in sharing information themselves, that they have something tangible that we can use as carers. So life story work is very, very valid. And it helps us develop care plans much better, but also have an understanding of the person, where they came from, what makes them them, to enable us to give our care in today. One thing that, again, we spoke about is the environment. So being in an environment, whether it's at home, a care home, a day centre, where there is over or under stimulating, can affect a person with dementia, and they can be extremely sensitive to the world around them. So moderate levels of stimulation is always going to be better. And when people with dementia are either overstimulated, we see an increase in confusion, agitation, or wandering. And where we see too little stimulation, we see withdrawal from the world and apathy and daytime sleeping. So it's getting that right balance in line with people's life history and what they like to do. So a diagnosis can bring a mix of relief, grief, all sorts of different feelings. And people need time and deserve time and support to process these. We often hear that families often feel isolated after the diagnosis and wondering what path, to take and what support and help is available. If you or someone you care for is having memory or thinking issues, the first and most important step is to talk to your GP. And the GP should take a full medical history, and they should look at your medication and carry out a very brief cognitive screening, which is something like a mini mental test, where they have a set of really random structured questions about doing repeat a word and who's the Prime Minister and where do you live, for example. It isn't a diagnosis, but it does support them to screen. And then we would hope that the GP would also run some bloods. After that, the GP may refer you to a memory clinic or an older people's mental health clinic for more investigation. And it would be there that you would have a more detailed cognitive screening. And if need be, they would give you some scans. And then following a diagnosis, they will hopefully talk to you about the type of dementia that they found. And then if after diagnosis, there should be medication and hopefully a plan of care. However, from our research, families have often said that they've kind of handed their diagnosis, handed their plan of care, and off they go. And we often find that the person who's living with dementia will have grief, anxiety, what now? And follow-ups can be variable depending on, the referrals, the GP, and what's available to you locally. So we do see a lot of people trying to fend for themselves. There are support groups as the Alzheimer's Society and Dementia Friends and local dementia cafes, all of which are very, very good to support with signposting. But what we want to do as a provider is also be part of that group, and we open our doors to, to networking events, dementia training for the community, and also support groups and memory cafes as well. So it really, it is a case sometimes of just having a diagnosis and getting on with it, but we want to bridge those gaps and offer proactive outreach. It's our responsibility to do that as care providers, absolutely. So there are many things that you can do to support your loved one living with dementia. And we do have a few tips to do that. So when a person with dementia is, exhibiting or maybe saying, I want to see my mum, or when am I going home? The best thing to do is never to confront or correct. Um, that is real to that person in that absolute time and place. And if they are wanting their mum, to them, their mum is still alive and she's still real. So what we do is we use a term called validation technique, and we never tell them that their mum's not here or their mum is passed away in, in 1945. We turn the conversation around and we would be like, oh, your mum, yes, you've both got, lovely brown eyes. And that way you're kind of you're acknowledging that they're referring to their mum, but you've distracted them away from wanting their mum, wanting to go home. And then you steer them away from that negative response. We often have residents be like, it's 5 o'clock, I want to go home, I need to pick my children up, let me out, let me out. So again, we'd be like, oh, you've got two boys, haven't you? And then, oh, what are their names again? So again, you're validating around the children, but you're steering them away from that negative element about wanting to go home. So we talk about going with their reality, climbing their bubble, and that's such a cliche term that we do use, but it really is absolutely, important to do that, because the world around them is very real to them. And we've been grateful and lucky enough to work with and to have links with a chap called Norman McNamara. I don't know if anyone's heard of him, but he's a younger person living with Lewy body dementia, and he set up the Purple Angel charity. And he talks about, and he can't remember the hallucinations, but he will talk about when he goes into a hallucination. He doesn't remember it, but the moment leading up to it, and it's very scary. So he needs a lot of reassurance to bring him out for that. So we can learn from people like that and how to approach people when they're experiencing behaviours of distress, to support them. Also, what's really important is caring for you and for you to take time out for yourselves. And we cannot forget the carers, the husbands, the wives, the daughters, the sons, the neighbours, because you are as important, if not more important. Your journey in this matters too. So we have lots of networking groups for families, and it's not just B&M Care, lots of providers do it because it is about utilising your local care home. And the care homes should be hubs in the communities, and they should be there for people. What we try to tell our lovely families and people experiencing is try and remain calm and relaxed, because if you're stressed out in that situation, the person with dementia will pick up on that and it won't serve anyone any good. We also say to families, establish a routine. Familiar routines provide comfort and structure, and they will ease any anxiety. Set regular times for meals, activities, and bedtime, and getting into a good sleep hygiene habit is really, really important too. Incorporate familiar activities and events, all the things they like to do, prior to dementia. Try and keep that going now. If it was a job around the house to do the dishwasher or put the bins out, encourage that person to do that. If it was gardening or hoovering, encourage them to do that. And we all need to have that sense of purpose. And things that resonate with their past and who they are, and it will support their psychological and social needs as well. We often say to families, avoid sudden changes. Things that are out of the ordinary, which can lead to confusion. Where am I going? What am I doing? And anxiety, which can then bring about more behaviours of distress. We talk a lot about communication, communicating clearly, face on, and slowly, and not to overload, because communication can become challenging as we've learned, to keep it simple and to keep things shorter so they can absorb and, respond. So there are many, many things you can do as well around the environment. We spoke earlier on about colour coordination. As we age, we lose the ability to differentiate colour due to an aging eye. So you have that, and then you add dementia, and maybe dementia that's affecting the occipital lobe, and then you have a bigger problem. There's lots of things we can do at home as well, such having colour contrasting plates, cups, crockery, a placemat of a dark colour, but against a white plate will give you a lovely contrast. And that's been, research has suggested that supports eating and drinking. We also have light surrounds to help people find and see the light switch. It's all these little things. Grab rails, aid independence, and try and move away from things at home that can cause hallucinations, such as geometric shapes and patterns that distort the vision, and also black mats and mirrors as well. We often get asked by families, what do you do for lack of appetite, problems with eating and drinking? So we often suggest that having smaller portions over the course of the day. We have lots of things we call grazing stations or finger foods, and that's food that can be picked up and support people to be independent but still have, good nutrition, especially if there's that lack of dexterity. Fortified shakes, milkshakes, smoothies, and lollies, and all drinks, for example, can all really, really support people. So there's a lot of things we can do at home, because dementia doesn't present one way, which is why it's important to cover off lots of different things, and hopefully they can help you and help your loved one. Um, if you're looking at care, so this is for care in the community. Most recently, I've supported a lady who came out of hospital who needed to find home care, and they were turning up at 11 o'clock at night in the morning, and she's got off, often got up at 6 a.m. and then she sleeps in a chair, but they're trying to put her to bed. All her routine, she was 92 years old, and her routine, she lived in the same house, and they're trying to come in and tell her, how she should now start living her life. Well, that shouldn't be the way. And even if people are being cared for and loved by loved ones at home or by external people, we have to make sure that we care people in accordance with their life history and their usual routine. And we talk a lot about this within B&M Care, and we adhere to the person-centered model of care. We also measure well-being, and well-being in dementia is how we almost measure our care if people are living well, and we use dementia care mapping, which was developed by the late Professor Tom Kitwood at Bradford University, who also pioneered the person-centered model of care as well. So we deliver person-centered care. Home care should also be person-centered as well. It's very important that we adhere to that. And I'm going to hand you very briefly over to Angela.
Okay, could you click on the next slide
Yes, I
then?
can.
Yeah, it's really just reinforcing what Caroline said and utilizing your local facilities in your towns where you live. Um, Places like care homes, the most communities have got a care home within them, so you can look to them to lean on for support. Maybe they host memory cafes. There's certainly a place to come to for networking and advice with other families. signposting you on. You can use a care home for recuperation, respite, holiday breaks. A lot of our homes run these memory cafes and support coffee mornings. Us as a provider, we're running these lovely discovery events, we call them, where you can find out, like you have today, about access about supporting people with dementia. That we run the virtual dementia tour, care funding long-term care is a challenge for people. One of the other things that we've launched in B&M this year is our complex dementia hubs. So that's a network of homes that look after people with much more complex needs and behaviours. Okay, next slide, please, Chris Whitty.
Yes, coming
Haven't
over.
said that for a long time, have we? So one of the things I just referred to there was our virtual dementia tour. It's a great piece of training that we deliver to all of our staff, but we also open that up to our families and the wider community. So if you haven't had a chance to take a virtual dementia tour, then you can pop back to our website and look at the next event. Like this event, it's a free event that we offer to families and our staff. Next slide, please. The next dates coming up for those are the 25th of September at our Borehamwood home and the 27th of November at our home in Baldock. That's a little link there to the website. You can go back on and book your place for that if you would like to. And next, please. The level one dementia awareness training. All of the staff in B&M homes have level one dementia awareness training. That's at the entry level, um, pretty much expanding on what you sat through today with Caroline, but it's a 2.5 hour training program that is accredited by Advantage Training. So we are able to give certificates of attendance for that piece of training as well. It's delivered by our head of training here at B&M. We offer it again free. So please take a look at that. The dates are up on the next slide for the next one, which is the 20th of October. And we run that in person. It's not virtual, it's in person at our training centre in Berkhamsted. Really just to wrap up today, as you can see from Caroline, she's very passionate. It is our passion. We're very good at delivering good dementia care. So come and spend some time with us at one of our community events. Sign up for the virtual tour or the dementia awareness training. If you haven't had a chance to look round a facility or a dementia environment, then please come along, take a look round. But that is just about it from us. Thank you very much for your time and attention. Have we got like a little sign-off slide there, Caroline, at the
Oh,
end?
we do.
Yes, we do. Yeah. So keep in touch with us. I hope you found this little webinar helpful, useful. We will email you an evaluation form today, along with the recording of today's session. The feedback that you fill in for us is really important. It helps us frame and develop the session for other people. You can also request that CPD certificate from us if you would like that. But that is just about it. If you have any other questions that you'd like to go into deeper, you've got our email addresses there on the screen. Absolutely happy to take any direct questions that you might have. Other than that, thank you very much for attending today. We will sign off. Goodbye, Caroline. Goodbye.
Bye.
Thank you very much, guys. Take care.
Bye. I don't know how to get off it. How do I get off it?